A very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Vikas, Khanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founders of SICOT Pioneer. And it's indeed a pleasure to welcome all of you logging into this webinar from all around the world. Now, in the COVID world of non-contact domains, we certainly got one thing right with SICOT, and that was we embraced digital competitiveness with the launch of SICOT Pioneer. And through this platform, we've done over 35 events and have had over 60,000 views from 110 countries around the world. So a big thank you for joining us and following us. Now, today's webinar, we'll be focusing on the treatment of soft tissue disorders on the disaster scene. We've got a fantastic faculty, and we're indebted to our disaster committee lead, Professor Herard and Professor Bar-On, for putting this excellent webinar together. As I said, we're also thankful to our stellar faculty who've given up their precious time for joining us on this webinar, and I will let Patrick introduce you to them in a minute. We try and make these webinars as interactive as possible, so please do post in your questions. And if you can't join us today, then you can access our on-demand portfolio as well via the SICOT website. Once again, a big thank you for joining us and hope you enjoy the webinar. Over to you, Patrick and Professor Bar-On.
Thank you very much, Vikas. It's a pleasure to start this webinar. We'll conduct it with Professor Gershon Volpin from Israel. Gershon Volpin is a professor of orthopedic in Haifa, and he's the chairman of the trauma committee, and is really especially involved in the teaching of polytrauma patients. Then we have Professor Bar-On, orthopedic surgeon and director of the Israel Center for Disaster Medicine at Sheba Medical Center. He has multiple missions to disaster area and very active within the WHO Emergency Medical Team Initiative and EU Foundation. Then Alan Kay is a burn and plastic surgeon serving with the UK Armed Force. He has a very extensive experience in dealing with acute wounds of war in conflict zones, as well as late reconstruction of complex injuries. So I will start with, we will start with my presentation, and I really wanted to start speaking of what is a disaster and how things are going on for an orthopedic surgeon. So, okay. So what is a disaster and what is a catastrophe? In fact, catastrophe doesn't mean disaster. Catastrophe is an event causing a great and usually sudden damage and or suffering. A disaster is different. It's an occurrence which will disrupt the normal condition of existence, causing a level of suffering that exceeds, this is the most important word, the capacity of adjustment to the community. What's the difference between them and what is the factor which will intervene is the vulnerability of the country where this event will happen. Just as remember, just rethink that 2/3 of worldwide population has not access to an affordable surgery. So the hazard, we all know what they are: earthquakes, high winds, storms, floods, landslide, volcanic eruption, drought, war, and it's of course the case in Ukraine now, and I think we speak a bit of it, civil strife, economic crisis, or technological accident. But it's not the hazard itself who lead to a disaster, but the vulnerability of the country. And this vulnerability is poverty, limited access, power structures, illness and disabilities within the population. So if you look at this map, which will give you the income per person and compare to the life expectancy, you can see that it's roughly a straight line. So your life expectancy will be totally different if you're born in Mali or in Mozambique or in Zimbabwe or in Niger compared to your life expectancy when you are in US or Japan. Then what is also more important is when you come and the line is nearly the same, it's the health expenditure per capita in US dollar in the countries. These data are from the World Bank, and you can go on the website of WHO and check where your country is. But of course, if you are living in the Democratic Republic of Congo, the average is $18 per capita per year. If you live in Europe, in the Euro area, it will be 4,000. If you are in North America, 10,000. So you can see that the multiplying factor is 226 when you compare these low-income countries to Europe, and more than 558 when you compare to North America. I just had this morning the level of Ukraine. And you can see the difference between Ukraine and Europe, the rest of Western Europe, let's say. And you can see that this factor is 16 and 40 when you compare to US. Just to have an idea, it's 248 in Ukraine, it's 653 in Russia, and 1,000 in Poland. So where these disasters happen, as you can see, it's mostly in Asia and Africa and Americas. What are these disasters? If you look at the average over 20 years, you can see that the most important one is the flood and the storms. If you think of the earthquake, and this is mainly generally the topic of our discussion, you can see that we have 28 earthquakes per year as an average. Now, when you go to an earthquake or a tsunami, you will see that things are really totally different. If you compare what's going on in for the last 5 recent earthquakes, the most important ones, from Bam to last in Nepal, you can see that there is the relationship between the injured and the dead is totally different. Roughly 1 dead and 3 injured. It's roughly the same for all countries. Totally different when we speak of a tsunami, for example, and the best example was Indonesia, of course, we all remember that, where in fact in this tsunami, the requirement for orthopedic surgeon is not really necessary. You have a very small number of wounded, and just a small number of teams will be really enough to deal with the problem. Most of the population they are dead. When we speak of the vulnerability, and as you have seen that it's a major factor, and if you compare the result of an earthquake in Japan and in Haiti, well, it's just 2 pictures, you can see that the main difference is the building in Japan are still standing on, or they are totally destroyed in Haiti. And you can see on the basement, if you go in an hospital in Japan, in Tokyo, for example, you will see that on the basement of the building, you have these special systems who will absorb the energy of the earthquake and who will avoid the building to collapse. So for the orthopedic surgeon, it's really a difficult context and need really a huge flexibility to react to unusual problem. The workload is huge. You will see a lot of late presentation, and some decisions are really difficult. Amputation or salvage, fasciotomy, do it or not do it, according to if the patient is seen after 8 or 24 hours, what to do? Do we do for a fasciotomy? Do we keep the leg closed? All these topics are really difficult. And of course, you need to shift the emphasis from doing the best to a patient for doing the best for a population. What you need mostly is to limit the consequences of a disaster, especially in terms of infection, by a very good debridement. And I think Alan will speak a lot about that, and what is a debridement and what is a good debridement, and why when you see a patient where we often go when we can see 3, 4, 5 debridements, this really means that the first one has not been done correctly. So, especially in terms of infection, so the debridement, external fixation, and of course, no internal fixation, and proper tissue coverage. Then you need to anticipate the reconstruction of what will happen for the reconstruction according to the socio-economic aspect of the country. There are obviously operations that you will not be able to perform, which will not be able to be performed in the future in these countries. So, of course, this is your OT, your usual OT when you go for morning to work. That's your OT, that's your table. It's sterile, it's nice, you have a Shyam, you have a good table, you have a traction table, you have everything. This is what you have when you are in earthquake. This is the example of IT. Your pre-operative room, it's just in the street, under maybe sometimes a tent or just a carpet or an envelope. And you need to operate in a container, for example, like this here. Then you cannot expect to have an acceptable OT before day 8 or 10. This was what we had in IT as an example, but it was really operational at day 12. So some decisions, as I said, were very difficult. I was speaking of late presentation, and you can see on the picture exactly what's the problem, and we face that. This is really not something that you are used to see in your home country, or these mangled extremities, or these really bad open fractures. So the burden of work for the orthopedic, it was really well explained by Karolinska Institute in Sweden, by von Schrepp. And we did this predictive graft. And this predictive graft, of course, the elective surgeries are gone. Your trauma is very high, but then you have this long curve with all the complication of your trauma and the indirect cause of infectious disease. And this was a predictive trauma. And if you look at the reality, and this is on 3 months time in Haiti, and you can see that the graph is correct. This predictive graph is totally correct. So the burden is really high, and don't think that when you go with a team, you just go for 1 or 2 weeks or three weeks. Don't forget that this is not the end of the story. This is just the beginning of the story. What you will face as an orthopedic surgeon, you will face open fracture of the lower limb. This is again on 204 long bone fractures in Haiti during the earthquake. You can see that 77% of the fracture on the lower limb were open. They were closed on the humerus, and it's easily explainable. During the earthquake, people just protect their arms, but cannot protect their legs. So all these topics are treated already by 2 previous webinars we had, and by the Congress in Budapest. Those who are still to be treated are during this actual webinar, and will be during the next Congress in Kuala Lumpur. But if you want to go a bit ahead, so you can see back these webinars and presentation of Budapest on the website of SICOT. But you may find, if you are interested by, these are 2 free books that you can download. Again, they are free, and just go on the website and you can have them. That's the first one was classification and minimum standards for foreign medical team. Then the second one was done by EO Foundation and ICRC, how to treat these problems of wounded. So as a conclusion, I just would say, just avoid this real common mistake. People just can fly for a few days there, relieve the burden of suffering with my expert orthopedic skills, doing a lot of fancy surgery that the locals can do, even doing sometimes, as we can see, some fancy surgery that they don't really know. And shift, of course, the emphasis from doing the best for the patient in front of you to the best for the population, and have a real important flexibility to react to unusual problems and limit the spread, the consequences of the disaster, especially in terms of infection by a good debridement, external fixation, and proper tissue coverage. This is what we will especially see with Elhanan. And provide safe, timely, effective, efficient, equitable, and ethical patient care with minimum standards. Thank you very much. So I will give we're now to Gershon Volpin, who will speak of the initial treatment of complex musculoskeletal injuries in disaster events. Please, Gershon, go ahead.
Yeah, but you have to go out from your lecture.
Yeah, okay.
Close your lecture, please.
Sure, that's done.
Okay, now let's try. I'm going to speak about the initial treatment of musculoskeletal injuries following disaster events in polytrauma patients. And we know that we have a lot of reasons for disaster events, including road traffic accidents, including war, including earthquake, etc., as Patrick said before. And we have to do, first of all, to do primary survey of the patient. And this is usually the best method is according to ATLS, where we look on the airway, breathing, circulation, neurologic problem, and exposure of the patients. Now, we have to take care about breathing. And the first thing is the tension pneumothorax and other problems that we had can be simple, or it can be tension, massive hemothorax, open pneumothorax, what's called sucking chest wounds, and flail chest. And these are, of course, to be treated as soon as possible in order to save life. And then the other thing is to definite if we are in a shock problem with inadequate organ perfusion. And of course, we have different causes like hemorrhagic hypovolemia, obstructive like cardiac tamponade, etc., cardiogenic shock, neurogenic shock, or sepsis. Everything of this.
Excuse me, Gershon, we don't see your slide.
How comes? So where is the Mr. that you didn't see any slides?
No. We see your face, but not your.
Where is Mr. Sofran? He said he's going to take care of it.
Okay, it's done now. Okay.
It's done? Okay.
Yeah, but you're not on slideshow mode.
I don't know what's going there. Where is the Mr. Sofran? He said, send me the presentation, I'll do it.
Here we go.
You see slides?
Yes.
You see number 8? Here, for example, you see the number 8 slide?
No, you see all the slides. You're not in Okay, now go forward.
Okay. So we see, for example, severe damage to liver, to intestine, and we have to take care about it. And pelvis, this is concerned with a lot of hemorrhage when you have the pelvic fractures, damage to internal organ. And you can see that the blood loss is differentiated into few degrees. And you can see that class 3 is between 1.5 to 2 liters. And class 4, which is the worst one, is about 2 liters. In this condition, of course, the condition of the patient is very, very bad, and we have to give fluids, and we have to give blood, etc., in the area of the event. And then we have to evaluate his neurological condition, and usually you do it with the Glasgow Coma scale, which take place for eye opening, verbal response, and motor responses. And then after you do the first resuscitation, try to move the patient as soon as possible to any medical center which is there. And if we are in the field, so we have a tent. If not, then we can come to a city center with a good hospital. So of course we have ambulances, sometimes we need helicopters, etc. But this is the idea.
You have to move forward with your slides. You're not synchronized. You have to move forward with your slides.
I am moving forwards.
All right, good.
Second thing is to do exposure and to do secondary survey of your patient in order to decide what's going to be your treatment. And we have to remember that the area of the event, disaster event, we call it primary hit, and the area of the hospital or the tent or wherever you treat your patient is the secondary hit. And we know that in severe multiple injuries of a patient, we are in the risk of development of systemic inflammatory response syndrome, which if it is high, it can lead to ARDS and multiple organ failure and death. And we have to prevent it. The average time that the sears come to top is about 24 to 48 hours. So in these hours up to the high place of the curve, the only thing we can do is life-saving procedures and then to wait until there is recovery, which takes about 5 to 10 days. If you don't do it, you can have the extension of this care, which can lead to all the complications that I said before. The best condition of the patient is when it is stable hemodynamic, stable oxygen saturation, lactate level is less than 2 millimeter, no coagulation problem, normal temperature, urinary output is about more than 1 millimeter per kilogram, and there is not any other problems that we can have. But in other cases, you can develop ARDS, acute respiratory distress syndrome. You don't see lungs. They are full with fluids inside, intravesicular, and between the vesicles themselves, and this can cause death of the patient. So today, the term is a little changed, and instead of running on the patient immediately with everything, we are going to another method which is called the damage control orthopedics. And this is based on initial evaluation of the injured patient and life-saving treatment, as I said before. And we start giving intravenous broad-spectrum antibiotics, tetanus toxoid, etc., blood, fluids, whatever necessary. And then we go to do initial treatment of the wounds, irrigation, debridement, removal of foreign body. We leave, in such cases, all wound open. We try only, if possible, to cover only exposed bones. And if it is possible, we are going on to do initial stabilization of the fractures only by external fixators, especially if you are in the tent.
Excuse me, Professor Volpin, could you tell me which slide are you talking? Because I cannot follow.
22. I'm now in 22. And you see external fixation is a safe, viable procedure, and you can use it, no complication usually, and you can use it in every place that we have. You see, in long bones, as one can see here, even of the pelvis, you can fit it without any problem. And this is a patient after debridement, and you see 3 externals for 3 fractured long bones. And this is another one. You can see also 3 externals after all, 4 externals, after debridement and first treatment. Sometimes we can have together and we don't feel the peripheral pulses. And if you try to do angiographic, and you can use it also under X-rays, if you inject the material to the femoral artery, you can see a stop, as one can see here, a stop of the blood supply. In a patient with multiple fracture, you see tibia, and you see the other tibia also and the other femur. So in such cases, we have to go to do the debridement, find the tear of the popliteal artery or the occlusion, to suture it, to enable blood supply, and then we go continue the debridement, putting external fixator and waiting for good recovery. In some patients, however, it is complicated by gangrene. Even if you do it again, you do the process, even if you put a lot of heparin, etc., sometimes you have to go to do amputation, and then after a few days, you can continue with external and change it gradually to intramedullary nailing, but this is not the topic of this study today. So in such cases, we saw that development of ARDS, or in the group of ETC, early treatment, you see about almost 20% of complication of ARDS as compared to the damage control, only of 8.6. And multiple organ failure, 12% in the first, in the early total care, versus almost half of it, damage control orthopedics. And we didn't find any super difference in that. There is a problem, as Patrick spoke before, about the mangled extremity problems. And you see here a child with his grandmother during war injuries, that both of them were severely injured in the lower limb. You can see this is the baby without amputated limb, became like this. And this is the grandma, and we couldn't save it, so we had to go to do
synchronize with the slides.
Sorry?
You are not the slides. Sorry.
Please don't disturb me. Now, in cases that severe situation of the patient, of course, when you have the ARDS and everything, you have to go to do primary amputation. And we can see also another marathon runner that came with such explosive injuries, and we tried to save his limb. We failed with that, the development of gangrene within few days, so we had to amputate it. But you can see is now fitting of prosthesis after 1 year. He went back to full marathons of 42 kilometers, and you can see that he got the champion of the world in such conditions. About pelvic. Pelvic injuries are connected with a lot of internal injuries, bleeding, etc. And especially if you have the displacement of symphysis pubis, deformity of the pelvis, open book fracture, etc. In such condition, we can use external fixation to close the pelvic. One of the most popular was in the Gans clamp from the 1990s. You see a small external fixator, only with one shunt, but can close the pelvis, stop bleeding in most cases, and enable also treatment and second look of the general surgeons, as one can see here. This is another case with the AO pelvic, look on the big external fixator with very good closure of the bleeding, and you can see also external of the femur. So in such cases, you can see closure of the pelvis, and then you can do after a few days or few weeks, depending about the condition, the final treatment of the patient. So in this chain, we have to remember that the initial day number 1, we do only life-saving surgery. And if the patient does not react to your treatment, leave it like that. If the patient is much better, you can go to early total care. During the next few days, there is the second look only, and you want to prevent extension of the systemic inflammatory syndrome and to prevent ARDS and multiple organ failure and death. And only after 5 to 10 days, you can, if the patient recover, you can go to do your scheduled and secondary intervention. However, when you do this evaluation, and if we are not orthopedic surgeons, you need other help. For example, epidural, big epidural hematoma, you have to do initial evacuation, tension pneumothorax, you have to do drainage. If you have fracture of the spine, you have to use collar at first, and when the patient condition enable you to treat you see here the fracture dislocation, go and do your open operation as soon as possible from the time, even after 2-3 days, you can do. This is with spinal fracture, same attitude that you have. And we see these injuries after all types of disaster events. In cases of dislocations of knees or tear of vascular, as one can see on the popliteal artery, we have to go and to do exploration, find the tear of the popliteal artery and suture it, and in about 60-70%, this can be full recovery. Other reasons for early total care, meaning do as soon as possible, will be either if you have compartment syndrome, or you have, as we said, we saw open fractures, then we have to go back to do all the debridement and primary fixation with the external fixator. So to conclude, our initial treatment must be, first of all, life-saving procedure with initial evaluation of the injured patient. And then going fluids, blood, broad spectrum antibiotics, tetanus toxoid, etc. And then we have to complete the initial treatment of wounds, irrigation, extensive debridement, and removal of foreign bodies. We have to leave the wound open, try to cover only the exposed bones, and to do initial stabilization of fracture by external fixation. Never do ORF, especially in TENS or the field, but only external fixation. Thank you very much.
Thank you very much, Gershon. Now, Alan will speak of the most important topic of this afternoon or evening, it depends where you are, about wound care. So, Alan, you will treat the initial wound care problem. And then the definitive coverage. Thank you very much, Alan. You're mute, Alan. You're mute, Alan, you're mute. Yes.
I should be unmuted now.
Yeah, okay.
Good, okay then, let's go again.
Alan,
with
you're
all
not
these things
you're
before.
not on slideshow. Sorry, Alan, you are not on slideshow.
No, I've got it down to sharing. I will come on to the end 1 second. Can you see it there on normal view?
We can see it, but not on slideshow. You're not in slideshow mode.
How about that now?
It's not going into slideshow.
On your PowerPoint, you have to go to slideshow.
Yeah, no, I had it on there. Let me put it onto window. Is that better?
Now we don't see. Wait a minute. Yeah. No, not slideshow.
Now we can see your PowerPoint, but please click on slideshow. Yes, at the top there. No.
Yeah, I was doing it down the bottom.
Yes,
so
then from the beginning. Yes, okay. It should work.
Is that now show everything?
From beginning, no. Click again. From beginning.
Yeah, that's from the beginning.
No.
Right. Shall I run it? Can you see the actual PowerPoint on there?
Yeah. Okay, go ahead like that.
Okay, I will just make that a bit bigger then. So, right. So sorry about that. Okay, so before you do anything, you need to think about things. Think about where you are. What's the situation you are in? Are you part of an acute response to a sudden onset disaster, or are you in a sustained response to a disaster that's happened many, many months ago? Are you actually just performing war surgery in an active conflict zone? And what's the environment you're working in? Are you truly austere? Is it just a compromised conditions? You might be in optimal conditions because the place which has been severely affected may still have a functioning healthcare system. And are you there as a surgeon in general to an undifferentiated patient group where you're being just a trauma surgeon in general? Or are you there with niche expertise, augmenting a functioning health service? And then also don't just focus on the wound itself. You've got to treat the patient as a whole. So you've got to look at the patient. Does the patient look well? Are they well? Look at their observation chart. Look at the dressing itself. But one of the things you have to accept is potentially in a disaster situation where you are working in austere environments, you may not have that normal support that you would expect at home to run your ward round. You will not have junior doctors and you may not have skilled nurses. So it requires a different mindset from you. And the key steps to making sure that your patient is okay, one, obviously, as we've just heard, you've got to stop the patient from dying, and you do damage control surgery and damage control resuscitation. And you need to correct any urgent anatomical disruptions. And then you need to prevent things from deteriorating. So this needs a bit of anticipation. You have to work out whether there's any leaking bowel, whether there's gross contamination, extensive multiple long bone fractures, large burns. All those things, if not addressed early, will actually then start to make the patient worse. And then you have to focus a bit more on the wounds itself. And this is where you have to come in and start thinking about, have you done a proper debridement? Do you know what all of the injuries are? Have you done any appropriate early repairs, correct skeletal stabilization, which, as we say, should always be external fixation initially, and then you come up with your formative plan. So these are the steps where you go. And all of this, as we already heard, was you have to balance between the best care for the individual with the best approach for the population. So when we're talking about general wound care, it is very much about general patient care. They have to be adequately resuscitated. They do need to have antibiotics, but that's synergistic with debridement. You can't not do debridement just because you're giving them antibiotics. Nutrition is important as well as general hygiene. And I will only just briefly cover about debridement here now, but a proper debridement involves a thorough evaluation of the wound, making the wound larger so you can get in there and find out exactly what's damaged, identify if you have to do any urgent surgical interventions, such as a revascularization, and then you have to get rid of all of the contamination, any devitalized tissue has to be removed. Then you start applying dressings after irrigating extensively with many litres of fluid. The general approach to wound care is having wounds makes a patient worse. It has a metabolic effect on them. So the earlier you can close a wound as possible is what you should be aiming for. But in the austere environment, and in after disasters and where you're dealing with war wounds, there are certain caveats to that we'll come on to shortly. At every opportunity, think about hygiene. Give the patient a really good clean. And what we're aiming to do is converting a wound such as this, which is a gunshot wound, to a forearm. When that's had a proper debridement, it needs to look like this, where the whole wound has been decompressed, effectively with a fasciotomy there. It has been thoroughly explored, the injured structures identified, it has been irrigated, and is now ready for a dressing. And following those same principles, we can convert really quite awful wounds from that into that, which is now almost a fresh surgical wound to manage. And we can convert something like that into this. As we say, though, the wound needs to be closed as early as possible, but where there is heavy contamination, there is any blast element, or you're working in a less than ideal environment, there should be no primary closure. This is not a safe way of approaching wounds. Now, very straightforward wounds are safe to close, certainly at 5 days, and possibly a little bit earlier if they are straightforward. Do not forget about healing by secondary intention. Often with multiple small wounds, these may not actually require surgical closure themselves, and they may sort themselves out with a bit of care and attention. Now, sometimes you cannot, having done a debridement, leave certain structures completely open. In particular, if you've done a vessel repair, nerves, or if the brain or dura are exposed, and potentially the eyes. So in that case, what we have to do is provide some sort of immediate cover to protect those areas. That is not the same as saying you close the wound. This is providing just some soft tissue cover from these damaged structures. And here's an example where you can see there on the top left, there's been a vascular repair performed. You could not just put some dry gauze onto that. This patient had had a fasciotomy correctly performed, and that can be converted quite quickly into a local transposition flap, which we did there, which was able to cover up that vascular repair. That was not primary closure. And then you have to think about what dressings are you going to put on your wounds. Now, the traditional International Committee of the Red Cross dressing is simple, dried, fluffed gauze. You do not need a non-adhesive interface, such as Toolgras, Gelinet. You just put the dry fluff gauze straight onto the wound, and then you secure it under a large crepe bandage and whatever sticky stuff you need to hold the bandage together. There's absolutely nothing wrong with that approach. It has been used for decades, highly successfully. There has been a drift towards topical negative pressure dressings more recently, and this came out of its extensive use during the most recent Afghan campaign. And I'll come on to that in a minute. There is no evidence of benefit of using topical antiseptic dressings. Simple, dry gauze is perfectly all right. And certainly, you must not be under the misapprehension that you're going to have your favorite dressing from your normal practice available to you in a disaster situation. And ideally, the dressing should be left until either you're going to do a second look of the wound, or at the time where you're going to do a planned, delayed primary closure. And what you mustn't do is try and overburden your system, which will have limited resources, with endless attempts just to change a dressing and to wound inspections, just to satisfy your own curiosity or to pat yourself on the back. Okay. You need to try and minimize the number of dressings that are done. Now, here is an example of a commercially available topical negative pressure dressing. And they are, in the right circumstances, highly effective and very good for the patient. However, it does require a reliable and continuous source of vacuum. If that dressing gets disconnected from its vacuum, it very quickly fills up with fluid, which gets trapped under the seal, and you can actually end up making the wound worse. It also requires staff who know what they're doing. So it is most certainly not the answer in all situations. But if you are confident in using it, you're confident in your source of vacuum, you're confident with your staff, then by all means you can use topical negative pressure dressings. But it should still be seen as a dressing. It is not a method of wound closure. And here's one way you can make it sort of an ad hoc version of it. So dry gauze on first, and then a bit of tubing, more dry gauze on top, an occlusive dressing on top, and then you just connect it up to a reliable vacuum source. Now, do you need to do second looks on your procedures? Well, If you're entirely confident with the completeness of your debridement, then the next time they need to go back to theatres, having had an effective dressing put on, is when you think it would be appropriate to do your delayed primary closure. If you have doubts about that debridement, then it is best to take them back in about 48 hours for a second look. And when you are dealing with blast injuries, you should never really be confident about your initial debridement. It's probably always worthwhile going back for a second look. And also put that in the context of the patient's condition. So if someone who you have planned to go back to theatres at day 5 for a delayed primary closure develops a fever on day 3, and there's lots of exudate coming out of your dressing, then they probably need to go back to theatres before then. And with heavily contaminated wounds, and certainly with blast injuries, you may need to be prepared to undertake serial debridement. That is where they need to go back to theatres several times. But don't just take them back to theatres just to change the dressing. Each trip to theatres has to have a reason for going there. If that involves a little bit more debridement, or if it involves doing a partial closure of part of the wound, but make sure you're making progress with the wound each time you go back to theatres. And this is a situation that you often find with blast injuries. So there was a very good initial debridement there, but at day 2, it looked like this. There'd been some further muscle dieback, which is not uncommon when dealing with blast injuries. And this needed another debridement of that now necrotic muscle. Another thing that you will be presented with is chronic wounds, either because of late presentations of the wounds related to the disaster or the conflict, or of existing wounds that were already there in the community beforehand. And I think the best approach to chronic wounds is for you to actually be patient. Don't try and rush into anything. Try and clean the wounds daily if possible. And probably giving them a vigorous rub is better than further sharp debridement. Dry gauze is still very effective as a dressing, but honey also potentially has a role here. And the sort of wounds we are dealing with, like this one, which is a neglected wound, you can see that if you went to try to do some further debridement here, it'd be really quite difficult to know what's going on. You might unnecessarily expose some further vital structures. Whereas if you just clean off the granulation tissue, get good wound hygiene, and look after the patient, you may turn that wound into a potentially a wound that enters a healing phase. That's all I'll say for now on initial wound care. I'll just pause for a second, see if any messages come along.
No, I think it's okay. I think we can go ahead, and then we'll have the discussion at the end.
Yeah, okay. So let's go on to... We'll just try it once to see if you can see it on full screen on this time. Do you see that on full screen?
No.
No?
No, it's the same.
Okay, then. Well, I'll do the same. I'll just try and maximize this screen as much as I can.
Okay.
Okay, now we'll come on to some of the options for soft tissue reconstructions. And it's the same again. Before you do anything, think. Okay, so reconstruction, that's the restoration and or the improvement of function and form. And you have to ask yourself the question, well, why are you there? What are you doing? Are you there to heal the acute wounds of a conflict or following a disaster? Or are you there dealing with the late elective reconstructions of established defects? Because these two patients are really quite different, but in the same situation. So have someone who sustained burns, a young child who's now developed burn scar contractures, certainly merits intervention, but should we? And next then there is the patient who has sustained an acute brachial plexus injury as a result in conflict there. They're two completely different patients with different needs. And then you have to look at yourself and you say, well, what's the scope of my competencies? And what is at my location where I am at the moment? What's our capability there? What's our capacity? And within the environment we're in, well, who's elsewhere and what can they do? What capacity do they have? And you ask yourself, well, am I really the right person in the right place at the right time to be doing reconstructive procedures? It's a bit different when you're talking about immediate life-saving things. Well, yes, we all have to just get on and do what we can to save someone's life. But to embark on reconstruction, that has to be much more thoughtful. You have to be honest with yourself and have some humility. And don't try and do something just because you can do it, but it may not be appropriate to the situation in which you are. But also, just because you're in a certain situation, don't embark on something that you're not trained to do, just simply because you think you're doing someone a favour. And do not plan to fail, because unless your patient is in a reasonable condition, then elective reconstruction won't necessarily work. The wound and the patient's general condition have to be as good as possible. And with that in mind, the wound itself must be now non-contaminated, it must not be infected, and the tissue that you're dealing with must be viable. Otherwise, your reconstruction will not work. And the patient, physiologically and metabolically and psychologically, must be in the best possible condition you can, and they must be able to integrate back into society at the end of it. So sociology comes into it as well. And with that in mind, then you can start to think about what are your options for reconstruction. Now, plastic surgeons were well used to dealing with this concept of the reconstructive ladder. Now, one thing I would say about this, what some people think about the reconstructive ladder is you start on the bottom rung, and if that fails, you go up to the next rung, and if that fails, you go up to the next rung. That's not the way this works. This is just effectively a list of options you have. And what you need to do is look at what you can do, what the patient needs, what condition the wound is in, and the situation you're overall, and choose the best option from that little checklist there. And if we start at the top there by healing by secondary intention, that's not an admission of surgical failure. Wounds will heal by secondary intention. They still require input with dressings, but that's certainly a perfectly viable option. Primary closures we do try and avoid in disaster and conflict situations, and the bulk of what is done is delayed primary closure. And for that, I include split skin graft as a method of delayed primary closure. Some things are not appropriate for that. So we go on to composite grafts, allografts, biological templates, things like tissue expansion. It is very rare that you would ever find a situation in an austere or a compromised position where that would be appropriate. And then we come on to flaps, which are extremely useful in this situation. And just as a gentle reminder, a skin graft or a graft in general does not have its own blood supply, and when you put it where you need it, it requires the wound bed to give it a new blood supply. Whereas a flap has its own blood supply and it brings it with it, so it's bringing a blood supply to the wound. And that's the fundamental difference between those two approaches. And out of that list, you must choose a method that will work for the wound, it will work for the patient, it will work in your hands, and it will work reliably first time. You don't want to waste resources by having a go several times. And the push still is to try and get wounds closed as early as possible, because wounds do have a metabolic effect on patients. So often getting a wound healed quickly by simple methods and then doing complex reconstruction later is a good approach in a disaster situation. Later on, sometimes rather than doing lots of simple procedures, it is better to actually invest resources in a single, more complex procedure rather than the whole series of simpler ones. But if you do that, you have to make sure you choose the right one, otherwise you are wasting resources. And the quality of care is often more dependent on the surgical team delivering the right care rather than the environment in which it's delivered. So what I mean by that is a good team can deliver good results even in compromised situations, whereas if you put the wrong team doing the wrong thing for the wrong reasons, even in optimal conditions, they may not get good results. Some equipment is essential, and you need to plan what you're going to do and make sure you take it with you. And don't forget that most reconstructive options produce a donor defect. So there is always a risk you could actually make things worse if you embark on the wrong thing. The skills, I think, that are essential for reconstruction would be a split skin graft, being able to do a full thickness skin graft, and some local random pattern flaps. What's desirable is the ability to do some distant flaps. And what can help is if you've got some books or even internet access, because there are a lot of these flaps, there are videos of how to do them available. And being able to repair tendons and nerves can be helpful as well. Another thing to think about is the various different parts of the body. Hand function is extremely precious and is worth investing a lot of effort in trying to improve even a small amount of hand function, whereas people can, even following amputation of legs, still function extremely well. So, but hand function is worth striving for. And what we can see here is and obviously a mangled hand, but with an appropriate and not particularly difficult reconstruction, we can turn it into a much better hand. And what's happened here is we've simply rotated one of the two remaining digits by 90 degrees, so it opposes properly. Most of the wounds have been closed primarily, and a small area that wouldn't close has got a split skin graft on it. Okay. So there's no huge surgical technical expertise involved there. It's the correct thinking process that was important in achieving that. Here is following a particularly deep burn on a child's arm. So what are our approaches to this? Well, a lot of those muscle bellies will accept a straightforward split skin graft. Towards the elbow, where it's more partial thickness burn, that will probably heal by secondary intention. But further down at the wrist joint, we can see exposed tendons. There's a possibility that there may need a tendon reconstruction later because EPL tendon has already gone. And there is exposed bone there. Two of the carpal bones are exposed. So quite a lot of that wound won't take a split skin graft. And we do need to use a flap for this. And here, if you look into the groin, we've marked out there. So this will be what would be described as an axial pattern distant flap. It's distant from the wound. It's axial because I can see, you can see my cursor there, that's a known blood vessel. You don't need to expose that blood vessel. It's always there. And when you raise this flap up, that is a very, very reliable skin paddle now, and you can close the secondary defect well. This can then be applied onto the wrist. Now, this was a different patient. I didn't have a photograph of that flap on a wrist, but it's the same principle. But what this involves is basically sticking the forearm into the groin for 3 weeks. Okay, so that is a patient factor you have to consider. Will that patient tolerate that for 3 weeks? Then after 3 weeks, you can divide it, and the skin that was there is now picked up its blood supply from the wrist and is now being vascularized. So that area, as we said, we did get some skin graft to take on there. We've now got a very nice reconstructed skin paddle on there. That will close later. A bit dodgy on that tendon there, but that might well carry on and heal. Another example now. This patient, to my mind, needed an amputation, but the patient refused. And that's another premise that you have to be reminded of, that even in an austere environment after disaster, you cannot do things without a patient's consent. You can't just willingly go and chop limbs off. He's already lost his forefoot there. But we've got a lot of exposed bone. But also we have a nice muscle there. That's the medial head of the gastroc there. So what we were able to do was move the gastroc muscle to cover most of the tibia. Skin graft will take over most of the wound, but there's still exposed tibia there. And that's, to my mind, that's not going to work as a reconstruction because we've still got exposed bone there. And one more example to show is an exposed elbow where we can simply transpose a bit of local tissue to cover that. That then creates this defect here. This will take a skin graft, whereas that hole wouldn't have taken a skin graft. So we simply put a skin graft on there, and the flap now covers the elbow joint. I'll mention briefly tendons now. There's no place for immediate repair of tendons in blast and ballistic mechanisms. The wound has to be stable before you undertake these. The best method is a simple core stitch plus an epitendinous suture, and I'll show you a picture of that in a second. But if you're going to embark on this, you must have a rehabilitation plan. It is pointless putting people's tendons back together again if you are not going to give them some form of supervised rehabilitation. Now, that supervision can simply be teaching them how to do it themselves, but you can't just do the surgery and leave it at that. If it's been more than certainly 3 weeks, then actually getting tendons back together again is almost impossible, and it will need a two-stage repair using a tendon spacer probably. And that's what I mean by a core stitch with an epitendinous stitch augmenting it as well. And don't forget, you have to rehabilitate the patients afterwards. And nerves, again, there is no place for immediate repair. You have to wait until certainly 3 or 4 days and the wound is stable. If you are going to do this, you do have to have the right equipment. It requires fine instruments, fine sutures, and some magnification. The epineurial repair is what is advocated. And again, you may need grafts if there is a significant gap. And that just shows what the principle of an epineurial repair is. But for both of those things, again, ask yourself, is me doing this surgery the best for the patient now, or maybe it might be worth leaving it until we go much more into the recovery phase following the disaster. And my last point is something else to avoid is, and while you're here, doctor, if you go to a place which has been a disaster or conflict, it is not only the immediate wounds and the immediate injuries. There will be things that have been in society for a long time, which, because they know there is a fancy doctor for some great well-developed country, suddenly appears. Things will start appearing, and they will want you to try and repair congenital abnormalities, burn scar contractures, established nerve palsy, things like chronic osteomyelitis. Do not get sucked into doing that sort of work in this situation. That's best dealt with by specialist teams at a later date. Thank you very much. I'll hand back now to Patrick.
Thank you very much, Alan. There was a question. I'm looking at the discussion. Yeah, okay. Perhaps discussion. Soft tissue reconstruction ladder, is it still advisable?
Well, it's a shopping list. That's all the ladder is. So if you have you'll have a copy of it there. There are other things I haven't mentioned, but it gives you an idea about what is available, what is appropriate from that shopping list in any given situation. That's what we're trained as surgeons to do. We're not simply technicians. We are people who think about things and we work out what the patient needs, and we apply it to a given situation. So think of the reconstructive ladder as a shopping list rather than a direction of travel.
Okay, thank you very much. Personally, I would have a question about, well, first of all, one thing. You clearly show the importance of the debridement, and the quality of the picture you showed us of the debridement for me is very important, and I think it's one of the most important picture of the whole webinar. I mean, people really, what we usually see on the field is that these debridements are not correctly done, they are not large enough, and they don't have what we call in French the parage, which is to enlarge the incision and so on. So thank you very much for that. Just a question about TPN. You clearly said that yes, there was no evidence of benefit. I'm very happy to hear that, but for me personally, I have some evidence of poor results and increasing the infection rate.
Yeah, I know. I think one of the difficulties is people think of TPN as a miraculous elixir, and that the wound is going to heal because you put it on it. I think if you start off with it, it is just another method of putting a dressing on a wound, and that's all you're going to. You're putting gauze on it, and all the TMP does is it helps manage the fluid coming off it. But you're right. The minute you lose the suction on it, then actually it's probably harmful. So to a wound, because then all of that fluid is trapped inside. So yeah, I mean, I do use it. I like to think we get very good results with it as a dressing, but it's not suitable for all environments, and you have to have a team around you that's also used to dealing with it and confident in using it.
Alan, how about wet to dry?
So you were sort of alternating wet and dry dressings. Is that what you mean?
Dry. Putting a gauze with saturated with saline, and it dries. The next day you change it. It sort of pulls off a bit of the granulation. I've had very good results.
Yeah, no, I
rather than
putting, because if you've got a wound there and you put a dry dressing on it, the wound is going to make that dressing wet. And I think there is something, certainly I think one of the features of why the traditional ICRC dressing worked was that after 5 days you'd have that gauze stuck to it, and when you took it off, it pulled away some of the top layer of the wound, and I think there was a bit of benefit in that. And in some ways we mimic that in what we do now in terms of the methods we have of scrubbing wounds at a change of dressing as well. So yeah, I don't think you have to necessarily formalise wetting it, letting it dry, pulling it off. But that principle of a dressing that has stuck on, pulling it off. That does mean, of course, you need to give the patient proper analgesia. Okay, I wouldn't advocate ripping dry dressings off wounds without the patient getting some form of analgesia or even an anaesthetic.
Yeah. Okay, good. Yeah, that was also another question from the audience. Why do you prefer dry and not wet gauzes on the wound?
I think the reality is, if you put dry gauze on, it's wet after a short while. So I don't actually see a difference between dry and wet gauze.
Thank you. So I will leave now the please, Elhanan, if you can go for the last presentation, surgery in disaster and environment. What is different?
I'll sort of sum up the most of the main points which have been brought up. I'll be summing them up. That's the last thing. I'll touch on something which have already been said. All right. Can everybody see this on full screen now? Can you see me?
Yeah, it's okay, Elhanan. Go ahead.
All right, thank you. All right, so what is different? Everybody, that's what we've been talking about. What is different in disastrous and austere environments? And there's many things different, but they definitely are different. I'm sure we're talking in the audience, there are people from a very, very wide variety of work environments in many countries. Some do have experience in disastrous and austere environments, some don't. So those who do, that's fine. But those who don't, we've seen, as I said in the initial stage, people coming and trying to do fancy surgery in austere environments, and that's sometimes it's better not to do anything at all. So disasters happen all over the world. They happen in developing countries. They happen, as we are seeing today, in much more developed countries. And there are all kinds of different varieties. We'll talk more about the ones requiring trauma, but remember, as we've seen in the last 2 years, that those are not the only type of disasters. And many times you will find yourself, you will be working in a very austere environment. And the places you'll be working in will have a low baseline capability of the local health system. This is further compromised by the disaster. If you started off at a low base, you'll still go to a much weaker, with less capabilities environment. Not only are the structures affected, but the medical personnel as well. Some of them might be killed or injured. What you see on the left is the nursing school in Port-au-Prince, with unfortunately, sadly, 150 nurse students buried there. But some of the personnel might be uninjured, but they will be at home looking for their relatives or looking after their relatives. And we accept that and we plan for that. It's a natural thing to do. So basically, we will be moving from a single patient during a routine time in a fully equipped hospital to the disaster scenario in which you will be in a damaged infrastructure area with an overwhelmed health system. And this is how it looks.
No one has said what it is. I need to know.
So this is Haiti, day 3 after the earthquake, a facility set up by the UN, hundreds of patients getting very, very minimal care, zero surgical capabilities. And for each patient you see here, there's another 100 or 200 patients waiting outside to get in. So what is common to all mass casualty and disaster scenarios is the extreme imbalance between the needs and the capabilities to meet those needs. And we will be working with shortages. And the shortages we divide into the 4 S's, as we say, S as in Sierra. And we're talking about space or structure. We're talking about staff. We're talking about supplies. And we're talking about the system. And if we talk about space, of course, the first place which will be overwhelmed will be the emergency room and the departments. People will be going to lying in the corridor. People are going to be lying outside. The operating rooms, again, in a trauma situation, will be overwhelmed, and the turnover time will be problematic. And you won't always have a sterile environment like Patrick showed you in Haiti. This is also in Haiti. You'll be working in a tent in a non-sterile surgical environment with very primitive facilities. The support systems, meaning the recovery room and the ICU, similarly will be completely overwhelmed. Moving on to staff. So in this scenario, traumatologists are going to be scarce. Definitely surgical subspecialties such as ophthalmology, ear, nose, and throat, etc. Pediatrics specialists, especially in military situations who are not initially or inherently built to treat children. And of course, the chronic shortage of anesthesiologists and OR nurses, which is our everyday life, also much more augmented in this situation. How about supplies? Well, obviously, fixation hardware, you're going to be running out very, very quickly. But it's not only the fixation hardware, it's the surgical power instruments, the C-arm fluoroscopy. Think about how many of these you have in your hospital and then multiply the need by 5 or by 10. And of course, autoclave, which is going to be a very, very narrow bottleneck. And the system. You have your SOPs for everyday functioning, but are these applicable? Are these good for functioning in a disaster, both within your facility and in coordination with another hospital, with a region, and with international bodies? So what are the solutions to all these problems? Well, you have to change your diskette. Conceptually, you have to change your diskette, both in the way you organize your hospital, both in the way you tap on your logistics and in your treatment priorities, your treatment methods, and even on your ethical considerations. Your goals are to increase hospitalization capacities, increase surgical capacities, and maximize utilization of what resources you have using your logistics. What solutions do we have? Well, a field hospital on hospital grounds is a good solution. It combines the forces and the power of a field hospital. On the other hand, it gives the field hospital the ability to tap on infrastructure like electricity, like water, like sewage, and that is a good combination. This, for example, is the Italian field hospital in Mozambique and Beira after the cyclone. You will have major changes in the hospital. In an earthquake or a conflict situation, you will be seeing mostly limb injuries, and the whole hospital will become initially an orthopedic hospital with a conversion of many areas into additional orthopedic wards. Your operating room will have to many times shift. This is again in Port-au-Prince, Haiti. You can see the operating room on the left, obviously completely non-functional, and the OR has been moved into just another room. Similarly, in Nepal, where in the Kathmandu military hospital, the operating room was moved into what you see is the VIP ward. But it's not only the operating room; it's the ICU, it's the lab and the blood bank. But you just can't move these places, these facilities into any room. You have to pre-map your potential alternative sites if you have the adequate electricity, the adequate gases, the adequate water or fluids. And you have to pre-map this so you know where you can shift your surgeries into. Remember that many of your cases are going to be superficial wounds and closed light injuries, as well as stress disorders. This should not be treated within the main hospital, but rather in the yard or even outside the hospital in order not to clog your essential facilities where they're needed for the more seriously injured patients. And unfortunately, we are going to have patients who are beyond saving, but we do want to give them an environment where they can spend their last hours or days comfortably, and we'll have to set up an area for palliative treatment as well. We want to increase surgical output and patient turnover. How do we do that? Well, one solution is to put two operating tables in one theater. That saves you an anesthesiologist who can supervise both patients, a circulating nurse who can serve both tables, and space, of course. So that is one solution. Remember, this is you're not doing clean surgery here. In the orthopedic tent, again, Haiti Field Hospital, so you can operate in the orthopedic tent. If you're overwhelmed, you can put a cordon there and then do the dirty surgery with regional anesthesia in the orthopedic tent. How about human resources? Well, you have personnel which are not specialized in, especially in orthopedics, but you can do task shifting. In the initial stages, the internal medicine people can change dressing. The young medic on the right-hand side, who'd never seen a cast before she came there, by the end of the deployment was an expert on cast. You can train them on site. And there is also what we call just-in-time training. This, what you see here, is from the last 3 days. There has been a major effort by AO to give on just-in-time training, and these are lectures which we gave over the last few days to hundreds of surgeons in the Ukraine who are not specialists in trauma, but we gave them a large number of people from around the world, gave a series of lectures trying to help them on the understanding of how we treat war wounds, how we organize hospitals, etc. What are the clinical implications? Well, as was said, damage control surgery, our priorities are limb perfusion, primary debridement, and the minimal surgery for stabilizing the fracture. Remember, you're going to have limited imaging and probably no C-arm in a field hospital, limited sterility, and limited instrumentation. And remember, if there's one thing you have to come out, all of us have repeated this, no open reduction and internal fixation in the tent. What's closed remains closed. The shattered knee can be fixed or changed in a few weeks when things are quieter or when they get to a real facility. You don't do open reduction and internal fixation in a tent. It's better to have osteoarthritis than have osteomyelitis. And optimize your surgical efficiency. Avoid long procedures. Keep it short. One slide we missed is regional anesthesia. Regional anesthesia is very, very useful in this situation because it saves you the recovery room, which is a very, very scarce resource here. So thank you very much. And if there are any questions, I'll be glad to take them.
Thank you very much. And from the audience, I haven't seen discussion. I don't have question from the audience. Sorry, no, I have. Would you consider joining an emergency medical team for training and deploying to a disaster zone? Yes, 80%, no, 20%. Well, that's a good news. I just have a small problem with that, is that you cannot go to a disaster zone if you don't have a previous training before. So training, yes, but deploying without training, no. For me, this is really this is a rule we have within MSF. For example, I don't send any primary mission to a disaster. They can go to the second phase and to learn there and to be taught there, but never go on the first phase without any previous experience. Gershon, your microphone is...
You're on mute, Gershon.
You're mute.
Don't worry. Now it's okay?
Yes.
I want to ask the faculty. We spoke only 2 sentences, I think. One of me and one of Ellen. To go more deeply. In the initial stage, the first day that we have the patient, we do a lot of extensive debridement, etc. But in some cases, we have exposed bones that the muscle around are not there. Or what? And I want to ask Ellen, or also both of you, the other one, what are you going to offer on the day of arrival in order to prevent open exposed bones on the limbs, especially the legs?
Okay, thank you, Gershon. Yes, Elhanan?
Well, I think Alan can give us an answer on the soft tissue. But one option you have to remember: shortening the limb. If you shorten the limb, you can many times gain a lot of this. Many times the shortening will be anyway because you have many times you'll have to do it anyway because you'll have non-viable bone. But even if you do, it might be, if you have completely no way to cover it, that might be an option. Number one, you can lengthen at a later stage. And number two, it's better to have a short limb than a chronic osteomyelitis. Alan, if you have any comment, or anybody else has comments on that.
A couple of comments on there would be, one is always be careful with language, because some people, when you say shorten a limb, they think that means amputation. What you mean is shortening the bone length, but preserving the soft tissue envelope. So yes, very often you can find that what appears to be a soft tissue defect, that actually disappears if you shorten the bone a bit. So it can make reconstruction easier, and that's a very valid approach. There are numerous times where actually simply putting a straightforward dressing on exposed bone doesn't really significantly affect the outcome. And there was a trial done in the UK. I know it's done in a developed world setting, but there was a basic putting topical negative pressure dressing on a wound, or putting on just a simple dressing, which was often just an occlusive dressing and nothing else. Okay, then there was no difference in outcome for that. If you are looking at getting the definitive cover within sort of 72 hours, something like that. So I would certainly think I wouldn't be worried about leaving some exposed bone just simply under a dressing, certainly for 4 or 5 days. I would, if that's the situation, I would suggest leaving them on antibiotics. The normal protocols are that you only need to give antibiotics as soon as first dose is as soon as you can, second dose is during the initial debridement, and then you give a third dose afterwards, and then you stop. I think if you have got exposed bone under dressing, then they need to stay on antibiotics until you get some cover. But I wouldn't get too upset about exposed bone under dressing for 3 or 4 days.
I'll tell you why I ask, because in some patients with severe damage to the legs, but viable bone, I'm not speaking about non-viable bone. I had a plastic surgeon who did some rotation flaps on arrival to cover just the exposed bone without any other maneuver. And with the broad spectrum antibiotics that we started, we got relative very high success of very high percentage of success with saving the limb. So is there a place, especially you as a plastic surgeons, to try to do, you finish the treatment, you clean the wound, you have good blood supply, do a rotation flap, cover the exposed bone, and then after a few days, go and do whatever you want to do reconstruction. Because biological dressing is the best dressing that you can have. This was the idea behind, and therefore I ask you these questions.
Yeah, no, I see where you're coming from, but I would say, and as you saw the picture I showed of using a flap to cover a vascular repair, that was done, immediately. But the risk there is that you haven't got an adequate debridement. And yeah, so you can do your initial debridement, and if you are 100% certain that that is going to work, and there is a simple, quick flap you could do, then yes, you could do it, but you are taking a bit of a risk. And I certainly think if there's been any element of crush injury, Certainly, if there's any element of blast injury, you can never be 100% certain of your first debridement. And what you don't want to do is to waste a reconstructive option by doing it too early. So I would tend to not do it for the first, and maybe the earliest do it would be about 3 days.
I'll say again, I don't mean to cover and to close the wound by rotation flap, because you have extensive debridement, extensive loss of skin and muscle, etc., etc., etc. And here and there you have places where you have exposed bone. So this partition surgery of right team used to do rotation flap only to cover the part of the exposed bone, not cover, not close the wound at all. I showed you, I think, about 20, 30 limbs during my presentation with after the debridement that you don't have any covering of corona. I don't speak about late reconstruction. I said about the primary treatment that you give your patient. This is one.
Thank you. We need
to,
sorry, we need to close this discussion. If there are no other questions, I will conclude, and I will touch my screen after the conclusion. So, as conclusion, we have seen the importance of damage control clinical approach, that we have to adapt and optimize our surgical efficiency. We have to be very flexible and react to very unusual problems, be safe, ethic, and efficient, and always follow the goal principle of good debridement, secondary tissue coverage, and external fixation. And at the end, understand the socioeconomic context in future perspective for your patient. Some of the questions we were said at the end will be treated in Kuala Lumpur. Thank you very much to all. I don't know if SICOT wants to conclude. I think so. SICOT is gone now. So thank you very much to all. Hope it was interesting for and I don't know if SICOT wants to say something at the end.
You can close the event, Professor.
Okay, you are closing?
Yeah, you can conclude the event, no problem.
Okay, it's okay. No, I already did my conclusion. It's okay, thank you.
I would add also one thing. It's so important to give all these patients tetanus toxoid on arrival without any connection to the time that they got the previous vaccination for them.
Okay, thank you very much all.
Thank you.
Good evening.
Bye-bye, good evening. Thanks for the seminar.
Bye-bye.
Bye.